Hello everyone, can you guys hear me?
Small, like 5 minutes. No data?
Yes. Hi Joy, hi Lisa, hi Sandra. Oh Sandra, you must be new. I don't recognize your name. So today we have a guest speaker for our meeting. She's really great. Her name is Tiffany Richens. So let me tell you just a little bit about her. She's going to be talking to us about high-level disinfection and sterilization. So Tiffany Richens is the project manager and educator for Advent Health Central Florida Division South. Tiffany has been an infection preventionist for 9 years and started her career in Denver, Colorado. She has a master's in microbiology and a master's in public health with a dual concentration in epidemiology and environmental health, and she's also CIC certified. Prior to working in healthcare, Tiffany worked in biomedical research. She moved from Denver, Colorado to Orlando, Florida 2 years ago with her husband and 2 sons to escape the snow and enjoy the sunshine. Oh, hi Yvette. You're in Utah. Wow, that's exciting. So hello from Florida. So without any further delay, I'm going to go ahead and hand it over to Tiffany, and I hope that you guys enjoy today's presentation. So come on over, Tiffany.
Hello. So today we're going to be talking about disinfection and sterilization, and this is a topic that's close to my heart. So as an infection preventionist, I'm by no means an expert in this field, but it's something that I absolutely have a passion for. I do think that your sterile processing department is the heart of the hospital. And so, getting to know this team and the staff, it's so important. And so what I'm presenting today is really about the things that I've learned as an infection preventionist over my time in the field, and just some of the things that I've seen and noticed. So, like I said, I'm not an expert by any means, but it's definitely a passion that I have, and I hope that I teach you guys something today. See if this works. Okay. So errors in sterilization and high-level disinfection make national news. So this is it's a huge thing, and it's so important for us to be able to make sure that we have everything in place correctly so that, we can prevent these national headlines. I'm sure a lot of you have seen these, and, these come out, and we've had national headlines come out even last year. So this is something that we're continuously having to focus on, making sure that we are partnering with our sterile processing teams to make sure, and our endoscopy suites, to make sure that, we're doing everything we can to prevent transmission and also any issues with the reprocessing processes. So just a little bit into definitions. So cleaning, disinfection, sterilization. There's 3 different steps, and so we want to make sure that that we all understand those 3 definitions. So cleaning is the removal of the visible soil. So we always talk about pre-cleaning. So cleaning is making sure that we basically get all that dirt and debris, blood, body fluid, all that stuff off of the equipment and the instruments. So that's what cleaning is specifically. Disinfection is a process that eliminates majority of the pathogenic organisms with the exception of the spores, right? And then sterilization is a process that destroys or eliminates all forms of microbial life, and it can be done through physical or chemical methods. So those are the 3 kind of definitions that we have in place. So, Dr. Spalding, you can clean without disinfecting, but you cannot disinfect without cleaning. And I love that quote because it's so important. I love it when people are like, "Oh, I'm just going to disinfect the surface." I'm like, "Did you clean it first? Because you can't disinfect without cleaning." So, Spalding's classification system. So we have, your critical, your semi-critical, and your non-critical items. So critical items are those that would normally enter a sterile tissue or the vascular system. through which blood flows. So all those items require sterilization. Semi-critical items are those that touch mucous membranes or skin that is not intact. So those all require at minimum high-level disinfection. And so this kills all microorganisms except for spores. And then our non-critical are low-level or intermediate-level disinfection, which touch only intact skin. Now, I know that if you guys follow Dr. Rutala at all, there's a lot of conversation about the classification system with Spalding, especially when it comes to endoscopes and duodenoscopes and, things that are taking biopsies and things like that. So they enter indirectly, they are entering that normal sterile tissue. And so should those items require sterilization? So that's definitely something that hasn't been resolved yet, and it's definitely something in conversation. So always something to look into. So this just shows you the decreased order of resistance of microorganisms. So, so of course your prions are the most resistant and, really can't, with those, I don't even think that they can be killed through sterilization. Spores, of course, can be killed through sterilization. And then as you go down, you have all the other things that are more and more susceptible down that pathway. So first we're going to talk about our semi-critical items, so our endoscopes, respiratory therapy equipment, anesthesia, endocavitary probes, things like that, so things that come in contact with mucous membranes. So for, high-level disinfection, there's multiple different disinfectants that you can use for high-level disinfection. Most people are using the most common ones are your glutaraldehyde, your OPAs, your accelerated hydrogen peroxide, and your peracetic acid. And they all have, again, different exposure times, different temperatures that they must be used to perform high-level disinfection appropriately. So you want to make sure that you read the IFU, pick up and read that bottle to know exactly what is required when it comes to length of time for exposure time, how to do rinses, all that stuff. But this is going to be your most common list of different disinfectants for high-level disinfection. So as always, pre-cleaning is like the most important step, right? If we do not do proper pre-cleaning, then we are essentially kind of setting ourselves up for failure. Pre-cleaning needs to be done at point of use. We want to make sure that we are getting all fluid, all bioburden off of our equipment at point of use. So this needs to be done as soon as possible after they're done using the instrumentation. With your scopes, in this picture, you have the sponge that you can use to wipe down the exterior of it. You should also have some enzymatic that you can flush through the lumens at point of use into your bag so that you can make sure that you're not only flushing and cleaning the outside, but also getting your the inside of those lumens. One of the things I've noticed at my facility is that, we're so busy. Our endoscopy suites, they are rocking and rolling when it comes to how many patients and stuff we're seeing. And a lot of times one of the challenges is being able to keep up with that flow. So even after those scopes leave the bedside, leave the procedure room and go into the dirty side of your of the contam, sometimes those scopes are sitting still before they're being able to get into the sink to be cleaned. So you want to make sure that this pre-cleaning process is done and done well. So it would always be a good idea, if you can, to get in there and to kind of watch through that process to make sure that they're following all the steps they need to. I think on the test they call it pre-cleaning, but I don't know for sure on how the test calls, ask the question. So I don't know, Maria, I apologize. Ultrasound probes. So again, ultrasound probes. So, this is one of the things that I think is a challenge for a lot of different environments when it comes to these types of probes, especially with pre-cleaning, right? So, most of our ultrasound suites, they don't have a double sink. They don't have proper space to be able to do really good pre-cleaning processes. So making sure that you find out and make sure that they have something in place. A lot of these enzymatics, they come in sprays and things like that. Some of them are pre-diluted. Some of them are, the staff need to dilute. If they are using one that's like a 2x concentration or something like that, or whatever concentration it is, if it's not in their pre-ready-made form, make sure that they have measuring devices in place to do proper dilution of that enzymatic, but also that their secondary container meets all the requirements for having the chemical label on that. A lot of times when we go around, we find that they're using a Prolistica, right? They're using a 2x Prolistica, and they need to dilute that down. But when they put it in like a secondary spray bottle or something, they don't have that properly labeled. So you have to make sure too that all those different things are followed, and that the contact time with your enzymatic is being followed as well. So making sure that you have all of those different steps in place, especially for an ultrasound probe, because it's going to go immediately from that enzymatic wipe or whatever into your either GUS station or trophon unit for high-level disinfection. So making sure that you're getting that process done in an appropriate environment where they have the ability to wipe down the sink afterwards if they've contaminated the sink, because a lot of times it's the same sink as their hand hygiene sink, and covering all those different bases. The other part is that we always have to make sure, even with our equipment that we do high-level disinfection on, that we're always inspecting it to make sure that that there's no cracks or any breakdown in the equipment itself. So there's a couple different types of things that people are using right now for performing high-level disinfection of probes. And so the trophon unit is been on the market, I don't know how many years now. It's newer technology. One of the things I personally love about the trophon unit is that it's an enclosed system. It uses the activated hydrogen peroxide, but it just takes a lot of that manual work when it comes to maintaining the OPA out of the equation. So, because it's just a little cartridge that you put in, so it's a little bit more user friendly. And they use the little buttons for their test strips. So you use that, and they use that for every run. And then the documentation, I think, is a little bit easier. So trophon units are used, and they use an activated hydrogen peroxide. GUS stations. So GUS stations have a lot of different requirements. They have ventilation requirements. So if you do use a GUS station in your environment, you need to make sure that it's meeting all the requirements around a GUS, right? So there's 2 to 3 different bottles in there. One is always for your high-level disinfectant, and the second one is for your at least first rinse. You need to make sure that they are always placing it from the high-level disinfectant into the rinse right next to it. You're not supposed to be taking that high-level disinfectant outside of that station prior to it having its first rinse. And I will say that a lot of times when I've done audits, that's where I find the challenge is that they're taking the probe from the high-level disinfectant in the GUS station to a sink to do a rinse, when really they need to be doing it in the GUS station for that first rinse. It needs to have appropriate clearance, because a lot of times GUS stations aren't in that negative pressure room, and so this is basically creating that environment for you to meet the requirements of high-level disinfection, and making sure that you are having protection for your staff against the fumes and everything from the disinfectants. OPA. So it's effective against, Endoscopes, other heat-sensitive semi-critical devices. So at least in my experience, OPA has been the most common high-level disinfectant that I've used in terms of using it for a GUS station or a tray. In AERs, we've used different high-level disinfectants, but for like in a GUS station, it's traditionally been OPA. And the big part with this is that, again, you have to have your instruments pre-cleaned with a detergent and make sure everything's done correctly. But a big part, and especially if you had like a Joint Commission survey, test strips and the logging and documentation of your test strips is very, very critical. You need to make sure that you have those 3 positives and 3 negatives tested with the OPA for the test strips to validate those, making sure that the lot numbers match up on your documentation as well as what's on your actual bottle, dating those appropriately. And then the other part is that you have to make sure that you are taking the temperature of the solution. So you need to make sure that the solution is at minimum of 68 degrees Fahrenheit. And so, so sometimes that, you might have to change the temperature of the room to be able to get up to that temperature. The other part is that it needs a total of 3 rinses. So you need to make sure that when you do observations and stuff that you see those 3 rinses. And then if you're using something with a channel, you can always flush through those channels with a 70% alcohol and then dry the exterior. Documentation for OPA. So again, especially when it comes to regulatory bodies, documentation is huge, right? So it expires shortly after open, so they have to document when that solution was open, the bottle was opened. And then the other part is that when you pour the solution into the reservoir that you're going to put your instrumentation in, then it's only good for a certain amount of time as well. So you have 2 separate dates to keep track of. And then you have the date of your test strips that you have to track. And then, like I said, your QC results for your test strips. And then making sure that you have documentation. You have to be able to link the cleaning of your instrument back to the scope or device that you've done high-level disinfection on. And so there's a lot of different things that it takes in terms of making sure that you are documenting appropriately. There's a lot of opportunities in there to make sure that you're meeting regulatory compliance and making sure that you're following proper high-level disinfection. So every time I go into any area we're performing high-level disinfection, the first place I always start is the log, because if they're not completing the log right, then I know that we already have some opportunity and some potential issues with how we perform high-level disinfection. Okay. So here's a question. So which of the following is an advantage of OPA over glutaraldehyde? Is it A, OPA does not require activation? B, OPA is compatible with more materials than glutaraldehyde? C, it does not stain skin? Or D, no personal protective equipment is needed to handle OPA? So what do you guys think? Okay, I got a couple answers. Looks like the majority of you are thinking either A or B. The answer is actually A. So OPA doesn't require activation. So OPA and glutaraldehyde are compatible with just about the same amount of things. So those ones are pretty much equal. OPA doesn't require any activation. You literally can pour it in straight from the bottle into the reservoir for performing high-level disinfection. And then, of course, as with all disinfectants, you always should use personal protective equipment whenever utilizing any type of disinfectant, and especially with a dirty scope. So endoscopes are used all over the place, right? Especially for GI procedures. Contamination of a GI endoscope, so during use, On the inside, so the lumen of that scope, 10 to the 9th organisms, and on the outside, 10 to the 5th. So it's grossly contaminated. Yes, OPA does have to be deactivated before disposing, but not for use. You do need to neutralize it. So, like I said, semi-critical items require at minimum high-level disinfection. So, there are guidelines and recommendations and stuff about using like a sterilant, a chemical sterilant for like duodenoscopes, things like that. But at minimum, it requires high-level disinfection. And there's been tons of literature. I mean, if you go to Dr. Atala's site, and his publications, you can find all the different articles and stuff where inappropriate and cleaning and disinfection practices have led to cross-contamination and transmission. And so the incidence is low, especially in the inanimate environment, but endoscopes are a significant risk for disease transmission. So especially when you're talking about like endoscopy room design, especially if you're getting to the point where you're going to be designing and creating a new workspace, there's two different ways that, the ARN recommends, you have that workflow. It always needs to at least be unidirectional. So, like if you have a one-room design, you need to make sure that like dirty is always on one side, clean on the other side, and that everybody follows that pathway. So, so you don't have contamination to the clean side from the decontaminated side. So you try to, separate those two as much as possible. If you are able to have two separate rooms, having your decontaminated side as negative pressure is something that they will check on, and trying to have your clean work room positive pressure. So again, these are just kind of the endoscope reprocessing steps, and this comes from the Multi-Society Guideline for Endoscope Reprocessing. So, of course, pre-cleaning, right? And then it goes into the dirty side, and then we're going to clean it. We're going to put our endoscope in. We're going to put it in the sink, right? We're going to perform our leak testing. We're going to take all our buttons and things like that off. We're going to manually clean the scope with an enzymatic. So we're going to go through all those steps. Brushes, most brushes anymore are single use, so we want to make sure, and they're cleaning all the different lumens and channels available on that scope. So it's always good, and they should run that brush through the lumen until that comes out clean. So if there's any debris or anything like that on the lumen, they need to keep running it through until it's free of debris. There is recommendations that you do validation of this. So there's multiple different ways that I know of. I'm sure there's more. There's things like channel check, where you can run sterile water through the lumen of the scope after you perform the first cleaning step to see if there's any carbohydrate, blood, or protein left in the scope. You can also use visual, so they have the inspectoscope, where you can actually do visual inspection of your scope to see if you have anything missing or if you have any damage to your scope. And then after you have that proper cleaning process, then doing your high-level disinfection or your sterilize. So you can do either one. A lot of people are now using an AER for this process. Of course, you can do manual cleaning. It's not as effective, but AERs are out there, and there's a lot of different protocols and pieces to that. So make sure that you read, again, the instructions on how to use that piece of equipment, so that you can see how to properly ensure that those are cleaned, especially like the connectors that go onto your endoscopes. You want to make sure that those get cleaned and processed every once in a while as well, because, I mean, it is water and stuff and channels that run through it. So they do have recommendations on how frequently you need to put those through and do high-level disinfection with those, whether it be through OPA or some other methodology. So now with Reprocessing, from my understanding, every scope is treated the same way as though it's potentially infectious and that there was a potential organism. So if there was TB, ESBL, CRE, and if you and that's, I think, why there's a lot of conversation about transitioning and start using sterilization for scopes, because there is such a risk if the scopes aren't properly cleaned right with the harboring of those organisms. So I haven't seen any evidence that says that if the patient has anything, you basically treat all the same, as whether they're contagious, they're able to transmit infection. But I do know that there's a lot of conversation about going to that sterilization process, so using a chemical sterilant or low heat sterilizers for scopes. But I think that one's one of those things that they're definitely still having conversations about. And Dr. Rutala, again, if you go to his website, he has a lot more information and studies and stuff that support that. So after, so the AER will do like your rinses and things like that in the piece of equipment, and then when you go to dry it, you can use compressed air to blow through the channels to get anything through, or and a lot of times the AERs will do your alcohol rinse as well. And then storage in a vertical position to help facilitate that drying. So AERs, so we kind of talked about those, right? So advantages, there's a lot of advantage to using those, right? So they take a lot of the potential errors that come into the manual cleaning process. They increase the efficiency and the reliability of the high-level disinfectant. It's able to do everything it needs to do in a very systematic way. And it definitely reduces personnel exposure to chemicals, especially if you're using like a peracetic acid or something like that for your high-level disinfectant. Those are very, very strong smelling chemicals, and so it reduces your risk of exposure to all those different chemicals. And also, because of how the water is with the AERs, you're using the filtered tap water, so the water that you're using is it doesn't have as much of the mineral composites and things like that. Some of the disadvantages is that, they do have biofilm that can build up in the AER. That's why they need to have and, read through the manufacturer's directions to see how frequently they need to be doing cleaning, especially of those connectors that they use for the different scopes to connect it to the equipment, things like that. There's one that eliminates the needs for that pre-cleaning, but for the majority of them, you really need to make sure that pre-cleaning step is it's so critical to get all that done. And then you have to make sure that it's placed appropriately and correctly, because if you don't use the right connectors, or if you don't place the scope and the equipment appropriately, then you're going to have issues. So all of those different things are so important to making sure that you get what you need done. Always just issues for consideration. ATP, so some people also use ATP to check to make sure, but again, ATP, channel check, those two, they don't tell you if there's microorganisms in there, just, potentially other markers that would indicate that there was some type of a cell or a microbe or something like that present. So essentially it tells you it's not clean, but it doesn't really tell you why it's not clean. So you have that. And then always, you should only ever do environmental sampling if you see that there's a potential risk. So that's per CDC suggestion. So scope storage. So we want to make sure that it's a closed lock cabinet, doesn't touch the sides, things like that. If you can have it HEPA filtered, that provides that pressure. So there are some horizontal storage cabinets that you can use, but they have to be very intentionally designed for scope storage and drying. So the majority of scope storages are vertical. One of the biggest challenges with this is that there are some scopes that are so long, and so you have to do this without letting the scope touch anything and not be coiling, and then touching the bottom of the cabinet. One of the big things is that you do not want to put towels or chucks or things like that in the bottom of your cabinets to collect water, because that just creates another reservoir, right? So if you do every single day, they should be going in and wiping down the bottom of that scope cabinet. We shouldn't be putting scopes in there that literally have active drippings from them, so you really shouldn't have anything that is dripping down there. If they are, then they're not doing the appropriate drying step for the scopes. You want to make sure that all scopes are stored with their valves open, and that like all their buttons and things like that are attached. A lot of they have like little pockets and things like that you can attach to the top of the scope so they can maintain all their buttons and things like that. And then, the other part is that, the recommendations now is that, scope should be reprocessed if it hasn't been used for 7 days. So having a process in place so that everybody in the staff knows when it's ready to use. So this scope has been processed within the last 7 days and it's ready to use, and that communication. So, having a good process in place so that there's no errors in that regard. Endoscopes, their design really just puts it to high risk of failure when it comes to doing cleaning and disinfection. So, again, it requires low temperature disinfection. They have long, narrow lumens. All those right angles make it very, very challenging to be able to get things through and around the corner and be able to clean appropriately. And just the amount of heavy, heavy contamination. So endoscopes are not really designed for really easy cleaning and disinfection, which is another reason why, some places have been going to disposable scopes, things like that. There's a lot of different options anymore to try and combat these issues. And then, of course, the ERCP. So, with the NDM producing E. coli, the hospital went from doing a high-level disinfection to ETO sterilization. Not every place has ETO. So, that's where a lot of places have been going to, like, chemical sterilants and things like that for ERCPs to make sure that we're basically addressing that issue. I think one hard part with tracking and doing infection prevention for endoscopes is that it's really hard to do the surveillance, right? So we know that there's transmission of infection. It's happened. It's in the literature, right? But one of the biggest challenges with it is that it's really challenging to do surveillance for these, especially with organisms that might not specifically be like a multi-drug resistant organism or things that are epidemiologically significant organisms. And so, or patients might go asymptomatic, things like that. So that is one of the biggest challenges with that. Okay, so next question. So when performing an audit of the endoscopy department, the IP observes the following practices. Which one is cause for concern? A, single-use brushes are used to clean the scopes. B, equipment is immersed in enzymatic cleaner that is discarded every 24 hours. Leak testing performed on scopes after each use, or scopes stored vertically in a closed cabinet. Yay, you're all getting this one right. Yes, it is B. They need to be changing out their enzymatic cleaner after every use. Good job. Okay, so here's another one. I might have to slide in there twice. Which of the following must be documented when using soaking solutions for cleaning instruments? So do they need to have monitoring the temperature of the solution, monitoring the room temp, monitoring the humidity, or the time the instrument's soaked? So Was it A, B, C, or D? Yep, you guys all got this one. It's D. So yeah, so they need to make sure they're monitoring the temperature of the solution and the amount of time the instruments were soaked. And again, those two values are based off of what is in the IFU for that specific disinfectant. So the disinfectant definitely is different. I mean, even OPA, so Metricide OPA compared to Cidex OPA, even those ones are a little bit different. So make sure that even if you're using the same if you're using OPA, but you're using different manufacturers, that you read and make sure that you've read the directions and make sure that you're following what those say. Okay, so I'm going to move on to now sterilization. So does anybody have any questions about high-level disinfection before I move on? Doesn't look like it. Okay, so sterilization. So, so this is going to include your steam sterilization, your hydrogen peroxide gas plasma, ethylene oxide, and then I'm not going to talk about the other three, but just know that those are other types of sterilization. So again, manual cleaning of instruments, it starts in the OR at point of use. So instruments should not be transported to your sterile processing department with gross contamination. They're not going to be able to get all the blood off of everything, but they should not have any tissue, bone. The majority of that should all be removed before they're leaving the OR. And dirty instruments should be transported from the OR to SPD in a puncture-proof, sealable container that's labeled as biohazardous. So that's where all of it starts. My recommendation, if you ever want to watch your instruments, start in the OR. Do an instrument tracer and start in the OR. Watch them open the sets in the OR, watch the case, and then follow those instruments down to SPD. You're going to learn a lot. So instruments need to be cleaned underwater with a non-abrasive pH neutral detergent, so an enzymatic. Brushes and things like that should be appropriate to the size of lumens and the size of the equipment. Some of these can be used multiple times. They need to wash them at least every day, and some of them are single use. So there's a little bit of a difference. If they are using scopes or anything that needs to be leak tested, they need to be performing that as well. So this all would be happening on your dirty side of your decontam room, right? So they should have multiple sinks set up so that they can do the enzymatic clean and cleaning everything out and then doing a rinse cycle. A lot of instruments anymore, especially some with those fine grooves, have in their IFU that they need to be placed into an ultrasonic. Ultrasonic is going to help remove all that fine soil and debris that's in your instrumentation. So if you do not have an ultrasonic piece of equipment in your facility, you should probably find out if any of the instruments that you are using have it in their IFU that you are required to use ultrasonic as part of their instructions for use. So you want to make sure that you are using the ultrasonic as intended. So it's really just to help you get all that fine stuff out. The process of cleaning for ultrasonic machines is called cavitation. So that might be a word that comes up on the exam. So make sure that you know what that means. So it basically is just a high frequency of those microscopic bubbles that literally, like if you ever taken like jewelry or something to the jeweler, that's what they're doing to your rings and stuff too. It's literally just a whole bunch of like air and bubbles and stuff that go in. They'll use and it's able to get and loosen all of the debris and stuff like that in those little crevices. So after that, most of our sterile processing departments now have an automated washer disinfector. So this is going to be basically after they've gone through the sink, after they've gone through the ultrasonic, now we're going to put it in our washer disinfector. So, these are great. They remove organism, they remove soil. These are able and capable of performing thermal disinfection or chemical disinfection. So when the instruments come out on the other side, they are safe to handle, right? Because they've been disinfected appropriately. They have special adapters and things like that, so that, like, if you're using robotics or things like that, you can attach these special adapters for, like, robotic equipment, things like that, to help make sure they're getting into the lumens and all these different things. A lot of washers also use the water-soluble lubricant because that really helps prolong the life of your instrumentation. Chemistry is so crucial. So just a quick story, when one of the facilities I've worked at in the past, we were having horrible staining of our instruments, and we're having problems with wet packs. And when we kind of boiled it all down, well, one of the root causes that we found was that it was due to our chemicals that we were putting in our washer, as well as the quality of our water, that was actually causing staining. So basically it was putting all these mineral deposits and things like that onto our instruments, and then we basically baked that all in when we put it on in the sterilizer, and it was also making it so that it was holding more moisture, holding more water. So it was causing a lot of different issues. So if you're having issues, in your final product, sometimes it really goes back to your washer disinfector. So you want to make sure that, you kind of look at that whole span of what happens on that side. The other part is that you want to make sure that your equipment is performing a final rinse with either RO or DI water, because you want to make sure that basically you're taking all that mineral deposit out. You want to make sure that your instruments are rinsed and you get all that out. And one way to really know if you have problems with mineralization is look at the inside of your washer, or ask your team how often they need to descale their washer. So if they have a lot of white residue and things like that, or they're having to do frequent descaling to get rid of that, then you might have some challenges with your water. So that might be something that you can ask them about, and make sure that you're constantly evaluating to make sure. And then also look at your instruments, because you can typically tell when your instruments are starting to get a little dull and things like that, and if it's due to the water. So,
hey, Tiffany, this is Luce. I just have a quick question. If you could clarify, what are wet packs?
Wet packs, so it's basically when you put a set into the sterilizer and it comes out with moisture on it. And I talk about that a little bit later, so I'll get back to that. RO water, so that's reverse osmosis, and DI is deionized water. So it's basically just water where we've demineralized it. So with your washers, so if you're using one of those automatic washers, there are quality tests that they should be performing on these as well. At least if you're a very, very busy department, daily. If you're not as busy of a department, at minimum weekly. Each one of these should go on, it's a challenge test again, right? So you want to make sure that you are putting it on the most difficult part of your washer to clean. And it basically is just mimicking like dried blood and protein and things like that. And so it's just basically to see if your washer is able to get all that stuff off. And they should be logging this test when they're doing it. I know that there's different types of tests. Steris has theirs. There's another brand that's called a TOSI test. So, just make sure. So they also have to be doing a test on their washer, which a lot of people don't know. So checking their logs and making sure that they're doing that appropriately as well. So after your instruments go through your washer or through the manual cleaning process, then they'll go over to the other side, the clean side, where they will go through instrument inspection. Okay, So this is where the central sterile techs are doing manual inspection to make sure that they're clean, that there's no corrosion, that everything works and functions right, that there's no tears, that the teeth line up on, on the equipment, the sharpness of the blade, so they actually have, I don't know, like rubber band kind of things that are tensile to like how tough skin and things and tissue are. So they test all these things, and if they find anything, then they set them to the side to either get replaced or repaired. A lot of, we recommend that they make sure that they have magnifying glasses, things like that, lighted scopes, so that they can see all those different things. So again, these are just pictures of all the different things that they're looking for to make sure that our instruments are in good shape, because if whenever we see cracks and things like that, then that's where it's really hard to clean, and we could have potential for bioburden and things like that to be growing, and you can't properly clean and sterilize that. The staining that you see in that second picture, that just kind of shows when you're having some issues with maybe some water on why you're seeing some of that staining. Some people think it looks kind of rust. It gets confused with blood a lot. So you want to make sure that your instruments are always free and clear of all that. And then they're always testing for proper function to make sure everything's working. Because when the instrument gets to the table after it's been sterilized, that surgeon expects it to be ready to go. And then after they've done their inspection, everything, they'll start to assemble. All hinged, non-self-regulating instruments must be open and secured. There's a weight limit for your instrument sets to make sure that to avoid collection of moisture. So it would be considered a wet pack if you would see wet and moisture on the outside, but also if they open a tray in the OR and they see any visible moisture in there, they reject that tray as a wet pack. So those are all the different things, because there should not be any water that stays condensed in your instrument sets. Delicate instruments, so that they have validated tip protectors to make sure that, that especially if trays move around, that they're held together and they protect the tips. And then every single sheet, so every tray has a count so that they know when they open it, so that, they verify that, and then they also verify multiple times in the operating room to make sure that they have everything they need. So indicators. So, this one's always something that is something that you want to make sure that, I always ask my staff, but it's really important to make sure that you understand as well. So there are multiple different types of sterilization indicators, as well as a biological indicator. Not all of these are used anymore. So the ones that we use the most anymore are the Class 1, the Class 2, and the Class 5 indicators, and so those are the ones I'll go into with you guys a little bit more, as well as a biological indicator. So chemical indicators. So those are the ones like with the tape, or the on the rigid sets, the plastic. So literally, it's a lot of times it's just detection of steam, right? It's temp and humidity. It's making sure that the cycle gets up to proper temp and humidity, and so it has a color change that is associated with it. So that's what goes on the outside of the packaging. It's one of the very first things that you're going to see as a chemical indicator to show that it's gone through the sterilization process. So it's been put into the sterilizer. A Bowie dick is going to be used not for your gravity load. So if you're using a gravity steam sterilizer, you would not use a Bowie dick. This one's going to be for your pre-vacuum sterilizers. And so that's what it's testing. It's testing that you had all air removal, because the pre-vac sterilizers, they basically remove all the air from the sterilizer and they create a vacuum in there. So the Bowie dick is basically telling you that it's met those requirements. And so this should be run every single day. So a lot of times, especially, it's run first thing in the morning. So you can always ask them if, their Bowie dig. If you are running like your immediate use steam sterilizers in the OR, you need to find out if they're running pre-vac cycles or gravity cycles for immediate use to see if they need to perform a Bowie dig or not. And then the class 5 steam, so these are called integrators. And basically it's because they react to 3 of the 4 critical variables for sterilization, right? So they test for time, temperature, and the presence of steam. They put these indicators in the most challenging place for the steam to penetrate in a set. Okay, so if you have a multi-layer set, they're going to put one on every single layer in the most challenging place. So this is the way that we really want to make sure that the steam has got to this instrument and it is sterile, and we can prove that it's sterile. So that's what this indicator is for. So, we want to make sure that that's how they're always using it, and that these are checked, again, when the instrument set is opened in the operating room. And then you have your biological indicators. So you should always run these out. They recommend daily runs. If you're using an implantable, we always like to recommend that you're using it for implantables as well. Basically what the biological is it has a whole bunch of spores inside it, and then they have it in a challenge pack. So it's a whole bunch of different layers, and then they challenge the spores in this set, and then basically you go and you look and see if it killed all the organisms or not. And so they put it into a incubator so they can find out. I don't know what the CL is. So the BI, and you always want to have a control that you have that's with the same lot. So after incubation, so there's a lot of different BIs out there right now. Chemical indicator. We have a lot of different biological indicator brands out there. So I know there's a 30-minute BI that's out there. There's a 1-hour BI. There's different types of BIs that are out there. You need to make sure that the incubation time for your BI, there's a 3-hour BI, there's a 24-hour BI. So the biggest reason why, if you can get the biological indicator with the shorter incubation time, especially for 1 hour with steam, is that by the time you're able to read out your biological indicator, because it's incubated for that hour, your instruments are cool enough to touch and release. So if it's 24 hours, then that instrument has already cooled, been released, right? And it's put on a shelf. And so if a surgeon needs it, then they would have to say basically that they understand that the BI has not been read and they're still using that instrumentation on a patient. So it helps making sure that we've read the biological before we've used this instrument set on a patient if we use those shorter BIs. Even 3 hours sometimes, especially if you have high turnover sets and things like that, that they would want to segregate those instrument sets until that 3-hour time, incubator time, has passed before we release them, so that we don't potentially release organisms where we might have a positive biological comeback. They also use these for our biological. They have them for our sterads or our hydrogen peroxide gas and things like that. To answer your question, in my opinion, unless you have run the full cycle, I would not, because I would not release anything. There's multiple different steps and phases that you need to have. So if you abort your cycle, even if your chemical indicator has passed, I would not feel comfortable releasing that instrument set. Okay, so here's a question. So a biological indicator from one of the sterilizers in sterile processing turns positive. So what's the first action? Should it be to retrieve unused items from the load? Should it be to conduct surveillance of involved patients? To evaluate the sterilizer? Or to evaluate staff education on use of the sterilizers? Okay, so most of you got it right. So the very first thing you would do would be to retrieve any unused items from the load. So you want to make sure that any instrument set that was in that load is segregated and held back so that you can, reprocess everything from that load. You want to, and if anything had been used at that point, then you would absolutely start, doing those next steps. But the first thing would be to do everything you can to prevent that any instrument from that load from reaching a patient or from going out even into the OR, because that would be considered contaminated. So we want to make sure that we do everything we can to prevent those instruments from leaving the department and before they get reprocessed. So common causes of sterilization failure. So improper cleaning of instruments can lead to issues with it'll look like salt and debris, like discolorization, and so it might make it look like the instruments aren't particularly clean. Improper packaging. So if you've ever spent time in SPD, if they don't set up their trays appropriately, if they forget to put the filters in your rigid sets, if they do anything incorrectly, then that's going to cause issues with how your sterilization process works. If you have improper loading of your sterilizer, too much instruments in there, then you are not allowing for that steam to fully penetrate everywhere. And again, if you don't put your chemical indicators in the right place, then it might give you false assurance that you had proper penetration of the steam. And then improper timing and temperature or operation, then you could have you might not be able to properly invalidate that you've cleaned or killed all the organisms on that load. Again, records are so important, so making sure that all the documentation is done. There's a lot of systems anymore that are going to a barcode process, so they're not even handwriting them anymore. It's all electronic. Either which way, as the IP, you should be going in and making sure that everything is done and done well. And I'm running out of time, so I gotta go faster. Packaging materials, so there's lots of different things. There's the wrap, and then there's peel packs. Making sure that you know how those work and how effective they are. Again, peel packs. So peel packs, you always want to make sure that if you have to double peel pack, that the clear is to the clear. And that you check. Again, they have a chemical indicator on them that shows that changes color when they're exposed to steam or ETO. Rigid containers, you need to make sure that they have the filter in place, because that's where the steam is able to penetrate into those rigid containers, and that they always have that locking, because that's, again, another indicator on them. And with these, you have to make sure that you're doing temperature, and weight, and things like that to make sure that they're not too heavy and things like that. A lot of places use rigid containers anymore so that they reduce the risk of tears and things like that in their wrap sets, so that there's not holes in their sets, so that they don't have to recall instrument sets or reprocess instrument sets due to holes and stuff like that in the packaging. So this is just kind of shows you different layers of a set. So you would want to make sure that when you have a set like this where it has multiple different layers, that again, you're putting that class 5 in the most challenging place in those different layers. When you have wrap sets, again, basically how wrap sets work is that when you have them exposed to steam, those little holes in them act like pores in your skin, and so they open up in relationship to steam, and then they close up. And so, when they come down to temperature, so you can't touch these in between when they're not at room temperature. It's very important. And then if you have problems with holes and things like that in your rep sets, they do have transfer trays that you can use to help, which is what I have a picture of here. So steam sterilization, we use it because it's the most economical, and it has rapid processing times, things like that. So that's why it's the most frequent. We kind of went through all this already. So there's minimum standards. So again, IFU is so important. You have to make sure that depending on what type of sterilizer you're using and what type of sets you're using, that you follow the appropriate exposure time. So like I said, the pre-vac, a lot of times we use the pre-vac because it's a shorter exposure time. And so it's only a 4-minute exposure time. But again, your IFU for your instrument could be 8 minutes, could be another time. So you have to make sure that you know the IFU for all your instruments, and then use the exposure time based on whatever's the longest in that load. So those are all, again, it's why it's so important to know your IFUs. Proper loading and unloading. So when you properly load, if you see every single set is spaced appropriately. When I was taught SPD, I was taught that you should do the hand test. So your hand should be able to kind of pass between all the different sets in there for adequate spacing so that you can have full penetration. And then once they take the load out of the sterilizer, you want to make sure that you place the cart in a low traffic area where you don't have like direct exposure to vents and things like that, because cold air and hot instruments, you have water in the air, and so it can cause and lead to condensation to form, which will result in wet packs and reprocessing of everything. So that's one thing to make sure that you always have a dedicated space that you can use to properly cool your instruments, and never, ever, ever touch them until they've reached the room temperature. A lot of SPDs have like a temperature gun that they use so that they know when it's safe to handle. ETO, so this one's toxic and it's flammable, and not a lot of facilities have ethylene oxide available to them anymore. A lot of places are going away from it. The biggest challenge is that there are still some instruments out there that the only way that they've been validated for sterilization is with ETO. So I know that that's one of the things that keeps it in place, but a lot of things are kind of going away from ETO. Hydrogen peroxide gas plasma. So this is going to be your low heat sterilization methodology, your STERADs that you have. Again, it's going to have the same requirements for chemical and biological indicators. But how it works is that it's basically going to be used for your heat and moisture sensitive items. Storage, so you want to make sure that the storage of all your materials is, either if it's in the, your sterile storage is in a positively pressured room. Humidity and temperature are important to make sure that we don't have negative impact of our sterile supplies. So if you store your sterile supplies in an area where you aren't tracking temperature and humidity, that might be something that you want to look into. And then immediate use steam sterilization. I'm sorry if I'm going over. It should only be used for emergency use. You drop something and there's nothing else that's sterile that they can use, and so we need to use immediate use. You just always want to make sure that you're doing using, and then you track your logs. So you should always, as a team, track your logs for when you're using immediate use steam sterilization. I have a couple other questions in here, but I'm just going to pass through them really quick, just because I'm out of time. but because I really wanted to get to these last two slides, the infection preventionist role. So you're, the subject matter expert and consultant when it comes to epidemiology, surgical site infection, and all that associated evolving evidence that's out there. You should be going in and spending time in your perioperative service areas. Watch surgical procedures, do instrument tracers from your OR to your SPD, to your endoscopy suite, to your procedure room. Watch the whole process. That's how you're going to learn. SSI data is one tool for assessing, but it does not replace time spent in your OR and your SPD environments. When you do have SSIs, share this information with your SPD leaders, as well as your OR director, manager, and your surgeons. SPD tends to get forgotten quite a bit, and so we want to make sure that, that they're looking at their processes internally as well to make sure that there was nothing that they saw on their end that could have led to this infection. And then, like I said, try and get into your OR and do observations at least once a quarter, so you can interact with your surgeon, your anesthesia, and your perioperative services. I'm sorry I went a little bit long. Here are my references, and thanks for having me come. And if you have any questions, let me know.
Thank you so much, Tiffany. We appreciate you, coming on and doing this presentation for the group. It's like we really honestly are so grateful. We have a couple questions. So yes, I will be sending out the slides afterwards. Tiffany provided me with them. And also this is being recorded, so I'll be sure to also share the recording for you guys. I know that this was really, really heavy. There was a lot of really good information. So if you need to go back through and review any of her, PowerPoints or the presentation, we want to make sure that you guys have that possibility. But once again, honestly, Tiffany, this was a wonderful presentation, and we're so, so grateful that you decided to come on and help all of us. So if you guys have any, last minute questions for her, be sure to just type them in and she'll be able to answer them for you.
I know it was a ton of information. I got a lot of my information from the AAMI standards, from AORN, and from Dr. Rutala's website. He literally has all of his slides and stuff available for you. A good place, too, to go down is literally spend your day with your sterile processing manager. They will be so grateful to have you, and that's where I learned the majority of what I presented to you guys today.
All right, everybody, thank you so much, and I hope that you guys have a wonderful rest of your day. Bye-bye.